video I had talked how a drug is absorbed from the intestine and enters into the systemic circulation and produces a therapeutic effect. The therapeutic effect is terminated by distribution, metabolism and excretion. So in this video I will be focusing my talk on distribution of drugs in the body. So to understand distribution, let's see the drug distribution model. So the drug distribution model has a vascular compartment and an extravascular compartment. The extravascular compartment comprises of vessel-rich group which includes highly perfused organs such as liver, heart, lungs and kidney. So this is the first reservoir. The second reservoir is the muscle and the third reservoir is the adipose tissue. So when the drug enters into the systemic circulation, initially the plasma concentration is high. Subsequently, the drug distributes into the extravascular compartment. The vessel-rich group, which consists of highly perfused organs, receives the drug first. This is because the high blood flow increases the concentration of drug in these compartments. So, subsequently, the muscle receives the drug. This is followed by the entry of drug into the adipose tissue. So the muscle and the adipose tissue receives the drug late. This is because of sluggish blood flow. So there is slow and gradual increase in concentration of drug in these compartments. So this is how the drug distributes in the extravascular compartment and an equilibrium is achieved. Later, the drug diffuses back into the vascular compartment from the extravascular compartment. So in terms of exit of the drug exits from the vessel-rich group into the vascular compartment first. This is followed by the exit of drug from the muscle and which is in turn followed by the exit of drug from the adipose tissue. So the muscle and the adipose tissue receives the drug late, but the drug stays in the muscle and adipose tissue for a longer time. This is because of the large accommodative capacity of the muscle and adipose tissue for the drug. So as the drug is getting released into the vascular compartment, major part of drug is getting cleared from the circulation through elimination. So the resulting effect on the plasma concentration level is there is a decline in plasma concentration and the decline in plasma concentration is slow. On a graph, if the plasma concentration is plotted against time, initially the plasma concentration of the drug is very high. This is followed by a rapid fall in plasma concentration and this is due to distribution phase, which in turn is followed by a slow decline in plasma concentration and this is due to elimination. So this was about the drug distribution model. So how do we define volume of distribution? So volume of distribution can be defined as the fluid volume that will be required to contain the total amount of absorbed drug in the body so as to attain a uniform plasma concentration equivalent to that of the plasma at steady state. So the drug gets distributed into various body compartments that consist of an intracellular compartment and an extracellular compartment. The capacity of the intracellular compartment is 25 liters and the capacity of the extracellular compartment is 15 liters. So the total body water volume is 40 liters. So how do we calculate apparent volume of distribution? So let's say 500 micrograms of digoxin gets distributed in the body to attain a plasma concentration of 0.78 microgram per liter. So the volume of distribution can be calculated using the formula the total amount of drug that is there in the body divided by the plasma concentration at steady state. So if we plug in the values, the total amount of digoxin that is contained in the body is 500 microgram and the plasma steady state concentration is 0.78 microgram per liter. So if we plug in the values in the formula, it works out to be 641 liters. So 641 liters is 16 times higher than the actual volume, which is 40 liters. So this indicates that the volume of distribution we have derived from the calculation is the apparent volume of distribution. The word apparent means appearance. it appears to be the volume of distribution, but it is not the real volume, because the real volume is only 40 liters and the volume derived from the calculations is 16 times higher, which is 641 liters. So, secondly, it implies that the drug is widely distributed in the extravascular tissues and very less drug is present in the vascular compartment. So next, what are the implications of volume of distribution? So a drug which has high volume of distribution is widely distributed in the extravascular tissues and it is difficult to remove these drugs by hemodialysis, whereas the drugs which are confined to the vascular compartment are easily removed by hemodialysis. Secondly, elimination half-life of the drug is long for a drug which has high volume of distribution. Thirdly, volume of distribution helps to determine the size of the loading dose. So this is because the drug which has high volume of distribution is widely distributed in the extravascular tissues and very less drug is present in the vascular compartment. So a higher loading dose is required to achieve the therapeutic target concentration quickly. So if the drug has a high volume of distribution, the size of the loading dose would be large so as to attain the desired plasma concentration quickly. So next we move on to the factors which determine volume of distribution of drugs. So the factors are lipophilicity or lipid solubility of the drug. Second, molecular weight of the drug. Third, the tissue binding affinity of drugs. Fourth, plasma protein binding affinity. So the first one, that is lipid solubility or lipophilicity nature of the drug. A drug which is lipid soluble easily diffuses through the membranes and gets deposited in various body compartments. So it has a wide volume of distribution compared to water soluble drugs which are restricted to the vascular compartment. The second factor is molecular weight of the drug. High molecular weight drugs such as heparin and insulin get trapped in the capillaries in the intravascular space and cannot diffuse readily through the capillary walls. Therefore, they have a limited volume of distribution and the volume of distribution is low. The third factor is tissue binding affinity. So, higher the tissue binding affinity of a drug, greater is the volume of distribution of the drug. So drugs differ in their affinity for various tissues. So drugs which have high affinity for tissues are digoxin, chloroquine and emetic gets deposited in the liver, heart, lungs, kidney. Thiopenton and DDT are highly lipid soluble drugs and gets accumulated in the adipose tissue and gets slowly released as the fat starts depleting. Chloroquine and chlorpromazine gets deposited in the retinal pigment epithelium. Grisofulvin has high affinity for keratin and gets deposited in the skin, hair and nails. Tetracycline gets deposited in the growing bones and teeth and is responsible for the yellow staining of teeth. Drugs such as cisplatin, lead and arsenic gets deposited in the bones. Chloramphenicol gets deposited in the aqueous humor of the eye and ampicillin gets accumulated in the joint fluid. So these are examples of drugs which gets distributed in various extravascular tissues. So next we move on to plasma protein binding of drugs. Plasma proteins such as alpha-1 acid glycoprotein and albumin are found in the circulation. So alpha-1 acid glycoprotein binds to basic drugs and albumin binds to acidic drugs. So drugs differ in their affinity for plasma proteins. Examples of drugs which have high plasma protein binding affinity are warfarin, chloroquine and amiodarone. Whereas examples of drugs which have low plasma protein binding affinity are acetaminophen, acyclovir, nicotine, ranitidine. So what are the effects of plasma protein binding? Plasma protein binding acts as a temporary store for the drug because the drug is slowly released from the active sites of the plasma proteins into the circulation, so resulting in a prolonged duration of action of the drug. So the plasma proteins acts as a reservoir for the drug and also results in a long elimination half-life and a prolonged duration of action of the drug. Thirdly, drugs which have high plasma protein binding affinity are restricted to the vascular compartment and are poorly distributed in the extravascular tissues. Therefore, the volume of distribution of these drugs is very low. Fourth, high plasma protein binding affinity delays the metabolic degradation of the drug. This is because only the free drug is available for metabolism. Lastly, high plasma protein binding affinity reduces the amount of drug available for filtration at the glomerulus because only the free drug is filtered through the glomerulus and is easily excreted. So high plasma protein binding affinity reduces the volume of distribution, the metabolism and excretion of the drug. This is because only the free drug is available for metabolism, excretion, and this drug is mostly restricted to the vascular compartment. So next we move on to displacement interactions which are caused due to plasma protein binding affinity. So we know that the drugs differ in the affinity for plasma proteins. So two drugs which have high plasma protein binding affinity compete for the active sites on the plasma protein. So if the drug B has higher affinity for plasma protein compared to drug A, it displaces the drug A which is bound to the plasma protein and increases the concentration of drug A, leading to enhanced pharmacologic activity and increased risk of toxicity. For example, salicylates when co-administered along with warfarin displaces warfarin from the protein binding sites, increasing the concentration of warfarin, leading to increased risk of bleeding. So clinically significant interactions are observed in case of drugs which have narrow safety margin, for example drugs such as warfarin, digoxin, heparin, and also these reactions are observed in an individual in whom metabolism and elimination is impaired, so that the drug gets accumulated and this can result in toxicity. In a healthy individual, there are no serious consequences as the displaced drug is easily removed from the body by metabolism and elimination. So let us now understand the concept of redistribution. Now this is particularly observed for drugs which are highly lipid soluble such as thiopental. Now thiopental is an anesthetic agent which is ultra short acting, but it has a long elimination half-life. So why is it so? When thiopental is injected intravenously, initially it attains high concentration in the plasma. Since thiopental is highly lipid soluble and brain is a highly perfused organ, it rapidly distributes into the brain and attains high concentration in the brain. It slows down the central nervous system activity, rendering the patient unconscious. So the action lasts for 30 to 45 minutes, and since thiopental is highly lipid soluble, it crosses the blood-brain barrier, comes back into the circulation and then redistributes into the muscle and adipose tissue. So redistribution results in sudden fall in the plasma concentration, and this is responsible for the termination of action of thiopental. So the action of thiopental is 30 to 45 minutes, but the elimination half-life is around 11 to 15 hours. It can stay in the system for 7 days. This is because the drug is stored in the muscle and adipose tissue, and muscle and adipose tissue have large accommodative capacity. They have high uptake capacity, so the drug is slowly released into the vascular compartment for a prolonged period of time, and this results in a long duration of action and a long elimination half-life. So these are my references. Thanks for watching. Please like, subscribe and share.